morning, good afternoon, good evening, wherever you are, and welcome to the EHE 360 Global Conference. We are so glad you're here. I am Denise Robinson, Executive Director of the EHE Foundation, and I want to thank our conference sponsors, Adi Biosciences and SpringWorks Therapeutics, whose support has helped make this event possible. I also want to thank our donors who generously support the EHE Foundation. Thank you for sustaining our mission, and you have made this event possible. And last but not least, I want to thank our presenters who have given their time to be here today. We are so glad to have you and look forward to hearing your talks. I want to start by telling you a little bit about EHE 360. This started several years ago as a patient-led collaborative network. It's a project of the EHE Foundation, and it has grown into a sustaining collaborative educational forum. If you're not familiar with the EHE Foundation, this foundation is dedicated to advancing research that aims to find better treatments and a cure for epithelioid hemangioendothelioma. Ultimately, our goal is to improve lives. We carry out our mission by funding and supporting global research and by providing supportive educational resources for patients and families around the world. Truly, patients are at the center of our mission, and they're at the center of everything that we do here at the Foundation. So I want to tell you a little bit about 360, this conference. It's a two-day conference. So yesterday, we had wonderful talks in our science symposium, which was focused on translational research and data science. Today is our Clinical Care Summit. So now we're going to kick off our Clinical Care Summit, and I want to invite Dr. Brian Rubin, who is our first speaker, to kick off our first session, Exploring EHE Diagnosis and Management. Dr. Rubin is an expert pathologist at the Cleveland Clinic and a longtime advisor to the EHE Foundation. After Dr. Rubin's talk, David Casimir, who is our moderator for the conference, is going to join, and he'll take over the day from there. So welcome, Dr. Rubin. We are so glad to have you and look forward to your talk.
Today, I'm going to talk about sort of the pathology perspective on EHE, and the title of my talk is Understanding Your EHE Diagnosis. So let's go ahead and get into it. And I missed the beginning of Nam's talk, which actually was great. Everything he said, I totally agree with. So I don't know if he mentioned this, but there are two distinct subtypes of EHE, and they're characterized genetically. So the most common one, which essentially it's greater than 95%. I could tell you exactly the percentage because it varies. Some people have said as much as or as little as 90%. I think it's much greater. I've seen a lot of cases of EHE over the years. So that's the one that's characterized by WWTR1, which is also known as TAZ. That's confusing. The gene name is WWTR1. The protein name is TAZ, and it's a WWTR1 or TAZ CAMPTA1 gene fusion. So that's 95%. It's the most common form of EHE. Then there's a less common form known as YAP1 TFE3. I put 5% here. It's in the realm of 5%. And then you will read almost case reports of other weird fusions that are still EHE, like WWTR1 MAML2, for instance, would be one of the rare ones that has affected the heart, for instance. But mainly we're talking about these two major subtypes here that comprise the vast majority of EHEs. So here's typical histology. I'm not going to show a lot of histology pictures today, but what you can see here, hopefully you can see my arrow, is that there's these little nests of cells. And probably people aren't used to looking at tissue, but this pink stuff is matrix. That's just the proteins that the cells sit in. And then these little nests are the tumor cells. And so to me, as a pathologist, they don't look high grade. They look very low grade. They're very nondescript small cells. You can see the occasional red blood cell sit in here, but typically what we see when we see it in EHE is a very low grade tumor, not supercellular, sitting in this really abundant matrix. Our lab is actually quite interested in the matrix and how that affects things, but we're still studying it. We're not really prepared to talk about those studies yet. There's very little mitotic activity. There can be necrosis, but it's not a tumor that it typically rapidly divides and rapidly grows. Um, okay, and then people talk a lot about blood vessels and vascular differentiation. I just go back to this slide for a second. This is a very primitive tumor, even though the cells are endothelial and show differentiation. They don't form proper blood vessels. So it's not really looking like a hemangioma or something that would form blood vessels. But the way we get at that and show that it's an endothelial tumor, and that means a tumor that's got vascular differentiation, is we use immunohistochemical studies. In the old days, the people would use electron microscopy, but those days are gone. So the three major endothelial stains are ERG, CD34, and CD31. And none of these is absolutely specific for endothelial differentiation. So when I look at a pathology report and when I diagnose this tumor, I typically use all three of these markers. I like to see that all three are positive, and they should be in a case of epithelial hemangioendothelioma. You can get fooled if you only use one endothelial marker. The second thing is there actually are specific immunohistochemical markers for the diagnosis of EHE. So CAMTA1. So if you remember, I showed back here, CAMTA1 is part of the gene fusion of EHE. And so what some smart people did, it wasn't me, it was this Japanese folks, and then it was confirmed later by all of us, showed that you could have an antibody to CAMTA1. And interestingly, CAMTA1's not really expressed in adult tissues or, in fact, any other cancer. And so you could use an antibody as essentially a surrogate for the gene fusion, and it's positive in virtually all of those cases of WWTR1 slash TAS dash CAMTA1 gene fusion EHE. Now, the same is not true of YAP TFE3. So you can't use antibodies to YAP and TAS because they're positive on all sorts of things. And then you might think, oh, why don't you use the TFE3 for YAP TFE3? But the problem with TFE3 is it's not specific for the diagnosis of YAP1 TFE3. And we had a case years ago. I can't remember exact circumstances, but somebody had made the diagnosis of YAP1 TFE3 EHE, and it turned out to be an angiosarcoma, just expressing some TFE3. And so we don't recommend TFE3 for this purpose. So the real key antibodies here are CAMTA1, ERG, CD34, and CD31. Here's what they look like. So this is tumor here. Here's some normal blood vessels. So CD31 stains normal blood vessels as well as the endothelial cells. But you can see all the tumor cells here are brightly positive in this particular slice of EHE. Here's ERG. ERG's a nuclear stain. This one's cytoplasmic, so it stains the cytoplasm. And then over here, you can see these round dots are the nuclei of the tumor cells, and they're all expressing ERG. So with CD31, ERG, CD34 being very useful. And here's CAMTA1. CAMTA1 was thought originally only to be a nuclear stain, but it actually stains cytoplasm as well. So it's a nuclear and cytoplasmic, but this is a case of EHE. And with CAMTA1, I'm pretty comfortable that this is a case of EHE. And here's the case over here on the left side. It looks very typical for the diagnosis of EHE, these little sort of innocuous tumor cells, and then a lot of this myxohyalin stroma. So molecular assays, molecular stuff comes up a lot. I get a lot of calls and contact from EHE patients saying, should I have, the gene fusion performed on my tumor? So there's really two assays at play here. Anything that determines whether there's a WWTR1, CAMTA1 fusion or a YAP1 TFE3 fusion is useful. A lot of us in the field use these RNA-seq based RNA gene fusion assays. Archer, you may have heard. Archer's a company that got swallowed up a couple times now, and I'm not even sure what they're known. I think Archer still remains, but they make a nice fusion assay that a lot of us use, but it's very focused. Nowadays, you're going to start to see an evolution. We're doing this here at the Cleveland Clinic from these RNA-based fusion assays to just RNA-seq. What that'll do is it'll sequence all the RNA in the entire tumor. RNA-seq based RNA fusions are more focused and look at a subset of the RNA. RNA-seq will look at everything, and this is where everybody's moving. You'll start to see RNA-seq being used a lot, and we can still detect the gene fusion. Now, another question comes up is, should we sequence for CDKN2A or RB1 or P53? Sometimes you just get that with your assay. It's like additional information. But I personally, I don't recommend doing it clinically. It's very useful in the research. area, and we do study the genetic alterations other than these fusions, but we don't know what to do with them clinically. We're not sure. We think that some of them portend a worse prognosis, but it's really hard to know at this point. We certainly haven't done the studies necessary to prove that. We're getting there, but we do think genetics are the reason that EHE tumors progress and become more aggressive. At least I do. Okay, so diagnostic challenges. So the first one is that the real problem with the diagnosis of EHE is it's rare enough where people haven't seen a lot of cases, if any. Some pathologists have never seen a case. And so to make a diagnosis of EHE, you have to think about it. You got to say, is this possibly EHE? I've seen lots and lots of cases of EHE now. So when one passes through my microscope, I know it's probably going to be a case of EHE. And then the problem is, of course, that people, if they don't know what they're looking at, they'll start to do a variety of immunohistochemical tests, and they may end up with keratin positivity because it happens in a subset of EHE cases. And if that happens, they're probably going to call it carcinoma of some sort. And I know that it's happened many times that I've seen cases that were reviewed elsewhere and diagnosed as, lobular carcinoma of the breast. They turn out to be an EHE. So we'll get to this in a second, but you really want an experienced pathologist looking at your case of EHE, somebody who's seen a lot of cases, who kind of does that sort of stuff routinely. And there are a bunch of labs in the country that have a lot of expertise at looking at EHE. The other problems are that many labs do not have CAMTA1 immunohistochemistry. And for me to make the diagnosis of EHE, I want at least one of two things, and preferably both, which is CAMTA1 immunohistochemistry, and then also an RNA-based fusion detection assay, which a lot of labs don't have. And so you want to see at least CAMTA1 immuno being positive for your diagnosis of EHE. But fusion analysis is also nice to have and really characterize the case well. People complain a lot about the pathology charges. My take it is that they're minimal compared to any kind of treatment, and you really want a good diagnosis. So spend the money on getting a great diagnosis, because everything starts with the right diagnosis, and there are some pitfalls. So what are they? So angiosarcoma is the one I see probably the most, where people are looking at a case of angiosarcoma. They've now called it EHE for whatever reason. That's a bad miss. Angiosarcoma tends to be very much more aggressive than EHE, gets different treatments. You really want to know when you're dealing with a case of angiosarcoma. There is another related neoplasm called pseudomyogenic hemangioendothelioma, also known as epithelioid sarcoma-like hemangioendothelioma. That's a real mouthful. People these days stick mostly with pseudomyogenic HE. And that's another kind of similar neoplasm, really look like clinically and how it behaves to EHE, but it does have some peculiarities that are really important to know about. Like it tends to be sort of multifocal and soft tissue, like in an area of soft tissue. There's low-grade carcinomas, as I already mentioned. If it's if somebody does a carrot and it's positive, they could really get off track. And then they're talking about something like lobular carcinoma of the breast. There's another sarcoma called epithelioid sarcoma. It has a very specific therapy, very different than EHE. We really want to know when we're dealing with an epithelioid sarcoma. And then I've seen just everything else under the sun that EHE has been called, and things that people call EHE that are not. And so I get to review lots and lots of sarcomas each year. And so there are other things that you just would never think people would get confused about, but they do. And so that brings me to this slide, which if somebody has rendered the diagnosis of EHE on you or a family member or a friend, I strongly recommend to have your pathology reviewed by an experienced soft tissue pathologist at a major treatment center with experience in the diagnosis and treatment of EHE. And so we're happy to do it here at the Cleveland Clinic. We have 6 excellent soft tissue pathologists, but there are lots of other good centers, and you don't need to send it to us. We're always happy to work with you. And getting a second opinion is just standard in the world of pathology. You don't have to worry. I've had people say, I think I might be insulting the pathologist who looked at this first. A, don't worry about that. You need the correct diagnosis. And B, every pathologist is used to having their cases reviewed. It's just part of what we do. No problem. We're happy to do it. And it's not very expensive. Okay. It starts at several $100s, can go to a few $1,000s if they do some extra tests, but really you want that correct diagnosis. I can't state strongly enough how important it is if you have a cancer or may not even have a cancer that's been called a cancer to get the diagnosis right on day one, because it will dictate every aspect of your treatment downstream. Okay, prognostic markers. So YAP1-TFE3 is associated with a better prognosis. It's amazing. People can have a lot of disease and go on for years and years and years without a lot of progression. Some of them do progress, though. It's not a, doesn't mean you're going to do really, really well overall. They do better, but people do die of YAP1-TFE3 fused EHE. Low mitotic activity in these tumors. There's one nice paper out of the Japanese group where they sort of had a cutoff of sort of greater than 2 mitotic figures per 10 high power fields. It doesn't really pan out in reality. You can't use mitotic activity to stratify EHE cases, as Nam said so well. To me, the warnings that the pleural, peritoneal, or serosal involvement are generally associated with a very aggressive behavior and a poor prognosis. Once the disease spreads to the organ surface, to the surface of the abdomen and retroperitoneum, or onto the surface of the lungs, patients have a really bad prognosis, and we don't understand why that is. It's a really unusual clinical thing, but it's absolutely correlated with very poor prognosis. Treatment approaches. So I was asked, do pathological features influence treatment? And they do not. So really with pathology, we're just trying to make the diagnosis. Sometimes people will say, is that a liver lesion? They'll stick a core needle biopsy and we'll confirm that in fact it's EHE. But in terms of the actual features, at this point, not influencing treatment, at least at my center and in my practice. Treatments, again, based on clinical features. So localized versus metastatic, whether it's growing. Nam brought up in his talk, very important to follow these tumors when somebody has a new diagnosis of EHE. We want to know how rapidly it's growing because there is a really indolent phase in a lot of cases. And you don't really want to mess with the indolent phase too much. If you can pick off a couple lesions with, and I know somebody's going to talk about ablation, fine. But you don't want to be overly aggressive in a case of EHE that is growing indolently, at least in my opinion. So disease monitoring, currently serial CT or other imaging is currently the gold standard. Now, I think the future lies in ctDNA, cfDNA. So in other words, we can look for the DNA that's being shed by the tumors in the peripheral blood and detect it. We know we can do that. There's good data now. We've seen the data from companies and other people that are doing this where you can detect it. The big question is, would fluctuating levels, so when the levels of DNA go up or down, does that mean something about the disease? And what our hypothesis is that when the DNA increases in the blood, that would correlate with disease progression. And so we could follow a patient with serial blood draws, much better. Instead of getting a CT scan every 4 months, you could get a blood draws and maybe have like a annual CT scan or something. We really need to kind of work that out. But the idea would be you'd follow a lot of the activity in the blood. And we have a clinical trial that's going to be coming in this area. And we'll let everybody know about it when it launches. We're still like negotiating and trying to figure it all out. But there should be a clinical trial looking at this question rigorously coming probably next year. I would imagine that we would launch early next year. So just future perspectives, we really need a good way to follow EHE disease progression. I mentioned ctCFDNA. Other people have proposed serum biomarkers. I think those got a lot of problems with availability in different laboratories and whatnot. But let's see what comes of that. There's people working on it. Effective treatments are needed. We saw the oncology approach. Nam talked about it. What we really need is very effective targeted therapies. People talk a lot about TEAD inhibitors. I know you've heard a lot about them over the next. To me, that's probably where we're going to be heading. There are some good treatments that are coming down the pike, and we just got to find that very effective TEAD inhibitor that doesn't cause a lot of toxicity. That's going to be the thing. But many drug companies are in this space. We even have a program here at the Cleveland Clinic trying to develop our own TEAD inhibitor. So once we have an effective treatment, we'll be able to evaluate when to treat. That's a big question. So if you have a really effective inhibitor, does it do anything in patients with the indolent phase, or do we wait for progression to treat? And then I will say that participation in clinical trials is just critically important. If you have the ability to get into a clinical trial right now, please do it. It provides information on the drugs that are being tested. It'll help us to kind of, understand this disease and be able to treat it better. All right. And I think we're going to handle questions at the end. So I will hold now. Thanks very much for your attention.
Hi there. My name is Dr. Bowie. I'm one of the medical oncologists here in the sarcoma group at Stanford, and I've been managing and treating a lot of EHE patients over the years. And so my talk will be the management of EHE, a case-based discussion, and I kind of want to go over a bunch of EHE cases that I've personally, treated and managed, and because they'll have a little bit of a different flavor. So what is EHE? So EHE, as I'm sure a lot of you guys are aware, is epithelial hemangioendothelioma, and it's a vascular neoplasm that is most commonly diagnosed in the lungs or liver. You can see here on pathology, there's cords and nests of cells. In a lot of cases, it doesn't tend to be very aggressive per se. It's generally slow growing, or what we call indolent. It can metastasize though, and quite a few patients unfortunately do have tumors that spread to other locations, but for the most part, those tumors grow quite slowly, and patients can live for years and decades, even with metastatic EHE. Some do have aggressive behavior, though, which we'll outline, and that's really critical to understanding how to treat this disease in each patient. It's generally it's genetically defined by a specific fusion gene. The CAMTA1 gene is fused with WWTR1. You can see here with the in the pathology slides, you can see CAMTA1 staining by IHC, and then sometimes you have a YAP1 TFE3 fusion as well. On histology, there's usually minimal mitotic activity, atypia, and necrosis. So generally a more kind of low-grade look to it. But up to 10% can have malignant features, which make it more angiosarcoma-like, which is another vascular neoplasm, which is very aggressive and can metastasize. So the first case I want to talk about is illustrating the finding of pulmonary nodules. So I had a patient who I saw who was admitted for weakness and pain, and workup showed two new small pulmonary nodules, one about 0.9 centimeters and one 0.3 centimeters. And when you have multiple pulmonary nodules, you think about metastases, you think about tumor, and so these things are really kind of distressing to a patient when you tell them you have new pulmonary nodules. So this is the scan that was obtained in July 2025, patient with an 8 millimeter pulmonary nodule. So the first thing I did when I saw this patient, of course, when they came to see me, they already had a diagnosis of EHE because it was biopsied. So the first thing I do is I try to go back and see where are their previous images and see if this is a slow growing tumor or a fast growing tumor. And most of the time EHE is a slow growing tumor. So I try to find the earliest scan where I can see this nodule. And lo and behold, if you go back 4 years to May 2021, you can see, in fact, this patient did have a nodule about 2.5 millimeters. No one had told her about it. She had not followed up on it, which happens a lot of the time with these pulmonary nodules, is that sometimes patients are not told or briefly told about it, and then they forget about it because they didn't follow, they don't follow up on it. And so this nodule has been around for about 4 years and hasn't grown that much, from only about 2 millimeters to about 8 millimeters. So this again reassures you that this is an indolent behavior, that this patient can probably live for many years or decades with this nodule growing extremely slowly. So they had a biopsy which showed EHE. Here's the pathology finding, which shows diffuse overexpression of CAMTA, which is indicative of this specific CAMTA1 fusion. We discussed with patient multiple options, that this is an indolent disease and that active surveillance is an acceptable option because this grows very slowly and we can manage it over a long period of time. The patient kind of wanted to take it out because it was just 2 nodules. It wasn't a lot of disease. We got a full body scan, which didn't show any other evidence of disease in any other organs. So this is just localized to the lung, at least as far as we can tell. So the patient opted for surgical resection. So they underwent a right VATS with posterior and lateral basal segmentectomy. And the patient is doing well now. Of course, this wasn't risk-free. The patient did have some complications during surgery. I think they had a hemorrhage, and so they needed to go to the ICU for a few days. And so it was, opting for surgery did have some risks to it, but eventually the patient did well with surgery, and they're doing fine now. So again, this is illustrating a case of an incidental nodule that was found, ended up being EHE. A scan from 4 years ago showed that the nodule was there, and so it just kind of redemonstrates kind of the slow-growing nature of this disease. So this is case number 2. This is kind of illustrating what happens when you find pleural disease, which is a little bit of a different spin on it. So again, this patient was found to have an incident of pulmonary nodule seen on lung cancer screening. This tumor was a little bit bigger, 2.8 centimeters, here on the left-hand side is when I first saw the patient. And this patient actually had it, and so I went back and tried to find an earlier scan, and you can see that about 6 months earlier, they had the same nodule, and it wasn't that much bigger. It was about the same size, about 2.2 centimeters to 2.5 centimeters. So you could say, oh, this is kind of maybe a slow-growing nodule. Again, we don't have many years of data, but just like 6 months. But something where you could potentially think that this is an indolent disease. This patient had surgery to remove it, and the pathology showed EHE, so it showed a multifocal EHE with the largest focus measuring 2 centimeters. The patient did actually have it in 1 of 3 lymph nodes, and they also had emphysema as well. The patient went on surveillance afterwards, and then a new pleural lesion developed 1 year later. This was re-resected, and it showed pleural EHE and also malignant cytology and pleural fluid. And as an EHE physician, whenever I see pleural involvement, that really does kind of raise my suspicion and raise my alarm bells that this could have an aggressive course. Because if there's one risk factor we know for EHE for a more aggressive phenotype, it is the kind of pleural involvement, the serosal involvement, that really kind of can herald a more aggressive course. So here's the pleural nodule. Again, not that big. In February 2023, this was removed, and you can see just a couple months later, they now have a much more aggressive lesion even after removal. This is on PET scan, kind of showing a hypodense kind of fluid collection in the middle, but kind of this FTG avid rim area around it. So this is initially concerning that this could be an infection after surgery. Could this be an infection? An abscess and empyema, and so we treated with antibiotics. But unfortunately, this was a rapid progression of pleural disease despite systemic treatment. We tried pazopanib and radiation therapy. I think we eventually did end up biopsying it, which confirmed recurrent EHE and not an abscess. And the patient passed away just in January 2024, which is about a year or two after he was diagnosed. You can see here the February scan, there really isn't that much there besides the pleural nodule, which is in another slice. And just about 10 months later, you can see most of the right lung is involved with this EHE that's kind of crept up his lung right up here. So I think pleural involvement is something that definitely raises alarm bells that something more aggressive may be going on. So the next case is about liver EHE, because I know a lot of patients are diagnosed with liver EHE. They can have multiple nodules. They can be large, and it can be very concerning for patients to kind of have multiple large liver lesions. So this patient was had to have multiple hepatic lesions as part of a syncope workup. So again, kind of going along with the theme that a lot of these patients are diagnosed incidentally, that they don't know that they have a nodule, they don't have any symptoms, they don't have any cough, they don't have any shortness of breath. For lung lesions, they don't have any kind of abdominal pain. For liver lesions, they're just kind of found. And so they was biopsied and showed EHE. So the patient was considered for systemic therapy, liver transplant, active surveillance, and was ultimately decided on local ablation therapies by interventional radiology. The patient was briefly on pazopanib for less than 6 months, but discontinued due to side effects. So the reason why we were kind of more aggressive at treating up front is, first of all, we didn't have a prior scan, so we didn't know how aggressive these were. And when you first looked at the MRI, there were a lot of liver lesions. There were more than 10. You can see here that they are large nodules. I think the largest one was around 3 or 4 centimeters here. They were multifocal, and they look pretty aggressive. So we kind of went over all the treatment options, but the patient didn't tolerate the systemic therapy that well. Again, pazopanib is generally a okay tolerated drug, not as bad as chemo, but not as well as something like sirolimus. So we have done multiple ablation procedures over the past years. And here's the patient 7 years later with very good treatment effect. You can see that most of the nodules that were ablated show very good treatment effect. You can see you can't really even see these bottom 2 nodules anymore, and the top one is now just replaced by this post-treatment scar. And the patient is doing well, having just gone ablation procedures, not needed a liver transplant, not needed any sort of IV or oral therapy, and is doing well 7 years later with no symptoms. So I think, again, assessing the pace of disease is important at first, but just to reassure patients that even if you have multiple large liver nodules, these tumors can remain indolent and slow growing over many years and potentially decades. So I think ablation procedures and resections do have their place up front for patients to kind of manage these. And then case number 4. This is going to be indicative of something similar. We have a liver mass, but this case takes a little bit of a different course. So in early 2024, there's an incidental liver mass seen on CT scan done for kidney stones. You can see here, there's a mass here with a little bit of irregular borders and looking quite necrotic. The biopsy showed EHE. There were no other metastases on the scan. So again, just one nodule, so different from the previous patient. So the patient was taken for liver resection. And this is the picture that the surgeon sent me during the operating room, saying that they saw the liver on the dome, the tumor on the dome of the liver. But you can see here, there's some multifocal. The tumor here is the white part right here. This is the top of the liver, and right up here is a diaphragm right on top of it. And you can see that there are some multifocal spots in the liver, but more importantly, on the underside of the diaphragm where the tumor was abutting, the tumor seemed to have spread directly to the underside of the diaphragm. And because of that, they didn't want to subject the patient to a large hepatectomy because the tumor had already spread contiguously to the diaphragm. And so the patient actually underwent Y90 liver-directed therapy and actually treated this patient with 6 rounds of chemotherapy after the local liver-directed therapy, given the aggressive nature of the tumor spreading to a serosal surface, which again raises alarm bells. When you start thinking of pleural disease, when you start thinking of serosal surfaces, you start to think of a potentially more aggressive EHE course. I put the patient on maintenance pazopanib just because of the aggressive nature, and he was on it for 1 year with no significant progression. Was doing great, running marathons, able to work, was doing very well. But the patient, after about a year, began to have worsening abdominal pain, despite his scans being negative. And the PET scan, didn't show much else besides that his bowel began to have this quite intense activity that was growing over time. So you can see here, starting from the right, which is the most remote scan, to the middle, to the left, which is the most recent scan, you can see the bowel where the arrow is. At the beginning, when you first see it, the radiologist didn't even call it because it's normal for the bowel to have FTG uptake because it's something where the bowel just generally has uptake because it is metabolically active. But you can see over time, as this kind of developed, it's something that was very homogeneous and just looks like a very active process. They start to be concerned about peritoneal sarcomatosis or tumor lining the peritoneum, tumor lining the serosa. And so unfortunately, the patient, after months of kind of worsening symptoms, but his scans weren't really that indicative, was hospitalized, and we started him on aggressive therapy for peritoneal sarcomatosis with chemotherapy, as well as trying to start TPN. But unfortunately, the patient passed away just about probably a couple months after this latest PET scan. So the patient had worsening abdominal pain, unable to eat, lost over 80 pounds, and despite sirolimus and TPN, passed away. And this is the autopsy report that the pathologist sent me. And you can see here all these, the normal bowel here is over here on the left. You can see kind of this healthy pink tissue, but you can see here this very kind of mottled gray, blue tissue coating the bowel. You can see here, it's definitely right here, you can kind of see a representation of it where you can see normal bowel and this kind of coating as if you just kind of threw paint on it. And this is actually EHE involvement. So it shows significant involvement on the serosa of the small and large intestine and in the muscularis propria of the small intestine. So basically, the tumor had coated the lining of the intestine, has also gotten to the muscle layer of the small bowel. So the patient couldn't digest. So basically, the patient just couldn't eat. The EHE was choking off his ability to eat and to digest. And so unfortunately, that led to the passing away of the patient. And so this kind of shows you that there are some EHEs that can be quite aggressive. And though a lot of them are indolent, I would say most patients are not like this one or the pleural patient I showed before, but a lot of patients can have aggressive courses. So EHE management. So I think these 4 cases illustrate how complex EHE is. And so I think when you manage EHE, you require an expert that, as every case is different. In general, despite metastasis, EHE is slow-growing indolent. However, some patients can progress rapidly, especially pleural or peritoneal disease, as case number 2 and case number 4 showed, and you need to pay careful attention to symptoms and scans. I think if patients are symptomatic, but their scans are not that impressive, you still got to really pay attention to them because there could be something that the scans aren't picking up, as you saw in case number 4. Other options for treatment options include watch and wait or active surveillance, which is generally my go-to up front, especially if I have previous scans showing this tumor hasn't been growing very rapidly at all, or has been slow growing over many years. Surgical resection for focal tumors, local ablation procedures, and then systemic therapies such as VEGF inhibitors, sirolimus, and chemotherapy. So my approach is one, I assess how symptomatic the patient is. Is there potential for imminent organ damage? Two, assess the pace of disease. How fast is the disease growing? Very important to get old scans if possible to see how the disease has evolved over time. The burden of disease is slightly less important. Some patients, as in case number 3, can have a lot of liver tumors but still not grow for a long time. Consider local therapies for slow-growing lesions. So in some cases, or in a lot of cases, patients can have very long-term disease control with focal tumor resection or ablation. So surgical resection for the lung or the liver, or IR ablation for the liver, such as Y90, TACE, or IRE. Liver transplant is an option for multifocal liver disease, but it may not be clear when the right timing is. Liver transplant is a very involved procedure. Patients are very sick after they get their transplant. They have to be on immunosuppressants. It's a big change in life. And if patients are going to be alive for years and decades with slow-growing lesions, it may not be appropriate to do a liver transplant up front. So again, something you have to weigh with the patient and with your own interpretation of how the tumor is progressing. And finally, if the disease is growing fast, definitely consider systemic therapy. So in order of least to most aggressive, sirolimus, VEGF inhibitors, including pazopanib and cabozantinib, and then chemotherapy, such as Doxil, gemcitabine, docetaxel, and doxorubicin. So I think my 15 minutes are up, so thank you.
We're now going to turn to our last speaker in session 1, which is Dr. Venkat from the Moffitt Cancer Center, who's going to be speaking on management of EHE and the role of interventional radiology.
Thank you so much for having me. My talk's very different. Everything you need to know you learned in the first two. Here, just sit back, have a little fun, and if you can, share some of your experience. Take-home points is what I'd like everybody as they go on their cancer journey is to just when they need to meet an interventional radiologist. We have some unique things that we can offer that we don't even know we can do. We never do it alone. You'll find us in multidisciplinary tumor boards sitting there trying to be afraid of what someone might suggest, but always paired with one of our oncologists or one of our surgical oncologists trying to get us through. We have very, very close relationships with our pathologists because we want to get enough, but sometimes we don't get enough. And that's what we work together for. I just wanted to go over a few things that you may expect along your cancer journey and things I want you to know about yourself that you can share before you go through a procedure and get a feel for when a procedure is right for you. As kind of was mentioned very, very well by Dr. Rubin, if something's not growing, if it's not painful in what you're going through, don't touch it is kind of what I'd like to say. I know it's a weird thing to hear from someone who lives off procedures, loves doing procedures, but there's a right time, and that's the nuance that we have to learn as we go through. And then really, when it comes to your imaging, and I have a lot of patients that it takes me a couple visits to get them to like hold their CDs and get their pictures and let me show them pictures. This is you. This is your disease. You have control. So please be your best or, advocate a family member to document and collect your imaging as you go through because there's so much information and it's yours to have. Really quick about us, radiologists are already a weird group. We're very much so imagers, a little computer-based, geekier than other doctors, I think. And we live on lists, but we love pictures. So ultrasound, there's going to be no radiation. If you've had an MRI, kudos to you. I get claustrophobic, so I do terribly. But this is a beautiful study, especially in EHE patients, because the nuanced information you get of the liver is fantastic. Now, useless in the lung, because you need details and hard shots. So that's where we go for like an X-ray or CT. PET CT, not everyone needs it, but it's great for that like question of, hey, I treated something, it was hot before, and I'm looking at a year later, it hasn't really grown, is it still hot? So you get more of a functional imaging, and I would love to see the imaging field change to where I go there and I say, okay, I have EHE, the right functional test that gets me my anatomy, vascularity, and functionality on one test. We're not there, and that's where we need to go. Angiography is not just for us. You'll find a bunch of different specialties who use it, but it's definitely an active thing. We have higher doses, but it's all about getting treatments to the right spot and having a informed intervention. So where can you find an IR? Really, 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 really recommend ask your oncologist. They know all of us, and they always have someone that they already collaborate with. So you're already like one up on the relationship, and I think that translates to better care. When your cases are presented in multidisciplinary tumor board, one of us is there somewhere, and it may not be the right one. I personally cover sarcoma tumor board. It's a privilege, and it's a responsibility. That's important to me, but you can go to any of our societies. So SIR is on our side of the ocean, and CVIR is great in Europe. Many of us are kind of on both because we all know each other. And really, if you have questions about interventions right for you, do not sign up for an intervention. Meet us in clinic. As you can tell, I still miss my clinic in Miami. Dr. Raj set this up, and it was partially donated by a patient, and it was one of the best places ever. But we all have clinics. We all have clinic time. Just come and say hi. It's totally okay to ask a question. We're crazy people about labs. So whereas a surgeon has everything in their hand and open control, and you saw those images, I'm working through small needles and small access. So coagulation is a big deal. Holding supplements is kind of a big deal. And that's why we always often get extra tests. It's not for your oncologist to know. That's for me before I do an intervention. Allergies are important. It's going to trigger. And then if you want the good stuff like sedation we'll talk about, you really want to fast. And then for me, as someone who needs contrast, I'm a big fan of telling my patients, listen, you're going to spend the day with me tomorrow. It's a marathon. Pre-hydrate, because I'm not going to let you eat anything so I can give you the good stuff. So hydration is very, very important. Brief note about sedation. You know what you need. Do not sell yourself short and jump into general anesthesia if you don't need it. There's all sorts of effects that can come with it. Some of my patients I meet, they do just local and we get it done. I used to cover a VA and really my patients wouldn't ask me for anything. Most of us, if you're like me, I'd like a little bit of moderate sedation. So you need a friend. I need to see a ride to know that someone's going to take care of you after you take care of this. You're awake with me. Some of my patients will actually not like take sedation and we talk the whole time. It's the strangest experience, but it's fun. It's not like endoscopy. Endoscopy and surgery, they get an anesthesiologist all the time. We call for them if you do need an anesthesiologist. Happy to call them. You may have to meet them first. It takes me a little bit more time to get organized. Most patients, if they can tell you, have they had moderate sedation before? If you've had a port, usually done with moderate sedation, PICC line, local anesthesia, FNA biopsy. What's important to remember is as you go for interventions, we don't like causing pain, but there's very little I do that doesn't cause some form of pain. Lidocaine burns. Access is difficult, so we try to decrease you feeling the pain by adding the anesthesia. Many of you have done biopsies. These are just me and my drawings of some tools, and we're just going to simulate a little biopsy. So this is my drawing of a liver. What we usually do is image the liver, ultrasound or CT, get into the liver in a safe spot, put a cannula, and then you don't keep poking again and again and again. Through that cannula, you sample different portions of the tumor. Now, mistakes we make when we start off is, oh, you want to get right in the middle. No, you want to sample all the edges. I owe the pathologist an active edge. With EHE, it's a little tough because you image a little differently. So finding where I'm going to give the best sample is difficult. So be patient and let us take a little extra if we can, because more is going to give you more answers and then you'll have more to use for the molecular testing, which is, very important. There is risks aside from pain, which again, there's not a liver biopsy that I don't cause pain. I just try to mask it with all my silly techniques, but bleeding is what we really, really worry about. So just be honest about blood thinners. Everybody's on different things. You don't want to go for this. Who treats liver bleeding? It's me. So we will monitor patients afterwards. I'm not shy about keeping patients overnight. The other place I meet a lot of patients is lung biopsy. Lung biopsy is technically difficult on the patients, not easy. As you can see, I have a needle here going through the ribs, into the lung, crossing in there, trying to get the nodule. I've already caused a bleed. So what happens with lung biopsies? I worry about causing hemoptysis. So the tissue itself around bleeds and you cough up blood at me. It's very distressing for all of us involved. And a pneumothorax, so air leaking out along my tract. So these are my numbers. I do cause a lot of pneumothoraces, but I don't need that many chest tubes, but I also get a lot of tissue. I can never take it all. And a lot of patients ask me, but with small lesions, what I tell them is in some settings, and again, with the oncologist, you can take it and treat. So this patient, I was trying to get a 7 millimeter nodule. I can't put someone through moderate sedation. So we're going to do general anyway. So with the team, we decided, okay, listen, I'm going to biopsy it. And of course, as I'm biopsying it, I drop the lung. And then I'm going to try and ablate it at the same time. And then I gave a pneumothorax and a chest tube. It kind of happens with it, but those are unique situations, but that is something you can ask about. Now, if you have 12 lesions and none of them are growing, one, you may not need to biopsy it, and two, you don't want to go after ablating them. Don't touch something that's not growing. This is what we look for afterwards. It never really disappears. The lung will always tell you that somebody was in there, so it leaves a little scar in that corner. Ablations are long, especially when you're going to do nuanced ablation. And I know a lot of you have heard probably Dr. Raj speak about it. The short ablations are your thermal ones where you're going to do RF or microwave. Most of us are moving towards microwave. We're getting better ablation zones and better margins. But the longer ablations, and IRE is something I kind of want everyone who has EHE just to be familiar with as an option at the right time. You're talking about anywhere, never really 2 probes. Most of the time, 4 to 6 probes, multiple sites. Most of us who do nanoknife of EHE patients will try and treat more than 1 lesion and get more. So that takes time, and that's a lot of time under general anesthesia. So before you jump into liver-directed therapy, I want you to get familiar with the balance that goes through livers. Your liver is working hard. It's filtering all the toxins in your body. So you need that normal parenchyma to work. You don't need someone like me coming in there and jeopardizing your normal parenchyma. So this is what we look for, is how well is it functioning? How well are you forming protein? And these are all things we look there. If you're forming a lot of ascites, sometimes the liver is telling you, I don't need you to go in here and take out your normal cells. And how many prior therapies have you had? Because someone has already changed your liver background. And that's what we look for in labs. The other one I want to put in there is if over half of your liver is fighting disease, taking out even a small rind of normal liver can compromise your liver function. So you have to be very, very careful when you choose these local therapies. It sounds very exciting, but it can be dangerous. So quick shout out to Dr. Raj. He's my mentor. This is how I kind of got into this because I come out of Miami, and what he does with EHE is fantastic. If you get a chance to meet him, get a secondary opinion. Some of the work that I'm presenting here came out of the limitations of this. So while he got beautiful responses and beautiful local control, the average tumor size was about 2 centimeters, and he did much bigger. And many of us know we deal with these geographic areas of EHE sitting in your liver. So we kind of asked, like, is there something else I can do? So this is just this is one of my favorite nanoknife patients of all time. And we treated this lesion because it was just causing a ton of right upper quadrant pain. On CT, you can see I've kind of put the marker right underneath it. It's a vague sort of enhancing thing. The PET was great because it shows you it's bright. This is where you treat. And then this is me putting a couple nanoknife probes, trying to get in there, trying to avoid the gallbladder up there. And then this is the post-PET CT, and we followed him with PET every year, 6 months, to say that this area was cold. And that is a better surrogate for response in this particular setting. Now, what I'm proposing and what was talked about a little bit before is sneaking through the arteries to treat bigger areas. Now, we have so many tips and tricks. And what I tell everybody, and I tell my fellows, and I tell everyone is, you want the provider to use what they use because they use it all the time and they use it well. I do all these things. I'm always a bit of more of an ablationist than an arterialist, but I will try all these things. What we do is we borrow an artery and we get up into the liver and we treat the tumor. Sometimes we'll treat half a liver. Very seldom will we treat a whole liver at once. Again, it's all about preserving that parenchyma. And when we do it, the risks profile here are very much so related to our access and protecting the artery afterwards. So this is really a collaboration with your patient, because once someone's accessed your femoral artery, especially in the groin, you got to lay flat. And then the one case I want to show you, of course, I do something different. This is an upside down access in the liver. So this is a young patient, huge radial artery. So you can sneak in through the wrist. Cardiologists do this all the time, especially on the right, because the heart falls right down there. Us, we do it a little bit less because, like, why cross long vessels and do crazy angles and do what I call upside down imaging? Just wanted you guys to see an angiogram. So this is what you see. You see the arteries and you'll see this like vague enhancement. We've moved beyond that in most centers where you'll see us not even just do an angiogram. We'll ask for more. We're very greedy imagers. We'll ask for a CT scan and ask the question, okay, what artery is feeding my tumor and how can I prioritize treatment? Then you sneak the microcatheter out there and you put the treatment right into that territory, limiting your distribution to normal parenchyma. And this is what I want to see with response, but what I found is I had a hard time quantifying this response. Like it looks less gray and smaller. They're volumetric responses. So one of my, actually Dr. Trent kind of told us like, hey, start looking at them individually and looking at them in volumes and show that you have a reduction. You and I know that there's a reduction. Now, none of this is statistically significant. I meet very few patients, and it's a privilege to meet every single one, but we take care of them a long time. So that's what we're trying to get a feel for, like, are we making some degree of impact? And that's what we showed, like, hey, the volume went down. More important to me than even the volume, because usually when I jump in is it's painful, is if I can shut down the pain with a nice treatment, that is what I'll do. Of course, whenever I go to do something, I cause more pain. So when you go after any sort of embolization, radioembolization the least, chemo definitely, and my bland embolizations, I give everyone post-embolization syndrome. So nausea, pain, you're not hungry, and then we have all these tips and tricks that we try to reduce it. Just wanted to show you like what one kind of intra-procedure CT looks like, and you can see the enhancing lesions that have had treatment already, and that's us putting a small needle in there to kind of like decrease the flow. So what I'd like to invite you after doing today is to ask your oncologist about local therapies, but the question is good, but you have to listen to the response. Don't jump into anything if it's the wrong time. Always good to get information, but pick the right time in your cancer journey. And I really want you to own your imaging. You know what's changing. And if it's not you, you have a family member or a friend sitting next to you, give them the job. You are now your personal historian. Let them do it. It's fantastic. It makes my life easy. And then celebrate your knowledge. It is okay in your journey to realize you know more about this disease than many providers out there. This has been a real challenge for me, especially as I treat a sarcoma population. My patients are always often the youngest in the infusion units, the healthiest looking, and the most wonderful thing about working at a cancer center is no one looks at someone who's young and healthy and questions that they don't have cancer. You don't feel that guilt. You shouldn't feel that guilt. This is important to me. So I'm just going to leave you with this and thank you for your time. This is something that Dr. Osler used to read every day, so it helps me, like even if I have a bad day, reset. And happy to take any questions.
Excellent. Thank you much. Let's call back the session 1 participants, and we'll have some group Q&A here. And Dr. Rubin, I saw you flagged a question in the chat there. I'll just read it so everyone can hear what the question is. Someone had raised the question of what is the theory on what causes EHE to switch from indolent to aggressive?
Yeah, it's complicated to answer that on that chat. I somehow did a live thing and it looked like I answered it, but I never did. I was just typing an answer actually as Dr. Venkat finished her talk. So I think it's genetic. There's a lot of evidence that we have that it's loss of tumor suppressors that are associated with aggressive forms of EHE. We actually have modeled that in mice and published it. We've actually modeled it in multiple mouse models now, and so yes, if there's a loss of CDKN2A/B would be the most common, loss of P53, loss of RB1, we think that portends aggressive behavior. We've never proven it in humans yet, but it's one of the things that we really want to do, and we'll get to it eventually. It's going to be a hard thing to kind of pull off in real time, but you can see that. That it's generally associated with a worse prognosis. We just don't know what comes first, sort of pleural peritoneal involvement, or then the genetics. The question is, how does it all work? And so, but yes, we think it's genetically based. People have talked a lot about the immune system and how that might influence progression. I think it's not involved at all. From my perspective, it's purely a genetic progression.
Thanks, Dr. Rubin. I just wanted to make a note that Dr. Bowie has had to move on to another meeting, so he won't be able to join us for the Q&A. And for the folks who are participating, please make sure you put your questions in the Q&A box instead of the chat box so that we can see them and interact with them. In the meantime, I'm going to pose a question to Dr. Venkat. I think you might have some perspective on this. One of our patients is curious why they have had experiences with physicians reading imaging so differently from one expert to the next. Sometimes these are repeat images and sometimes it's the same image and a different person is looking at them. Can you explain a little bit why that might be the case for a person?
Yeah, no, it's a pet peeve of mine too. So I'm really, really bad. So when I was at my center, because I know my friends, so I would sometimes write in the notes like, I only want so and so to read my note. No, it's a function of what we're trying to balance. And cancer centers sometimes do it better. So when you have your CT scan, if I'm on the diagnostic radiology side, I'm already behind. So on my filter, like I want that readout to you quickly. So in the function of efficiency, it'll catch whoever's out there reading. And especially if you go to other centers where like it's really about turnaround time, they don't take the pause to say like, okay, like maybe wait until, Dr. Souza, who's, experienced in sarcoma, is on tomorrow to read it. So this is why a lot of us, and I think everyone can speak to it here, we make our specific readers read it. The other thing that I ask my patients so that I can misbehave is like, I will look and note when you have your CT scan, and then I'll
Mhm.
jump in the queue and like ask my friend here, it's Dr. Quarum that I bother all the time, like, hey, can you pick off my patient study just so I get that person?
Hmm. So
It's
it's provider to provider compatibility sometimes as well.
Yeah, it's this weird thing in medicine where sometimes we prioritize efficiency over almost to a degree, not quality so much, it's just the best choice. I don't know if anyone feels that way.
I certainly appreciate that perspective.
Well, I think imaging is not, people think everything's very black and white in medicine,
Mhm.
and it's not. There's a lot of gray. That's why you want a very experienced person reading an image, or just as you would a very experienced pathologist. And that's why things differ. So you want experts looking at your stuff as much as possible. I totally agree with Dr. Venkat, and not rushing.
Question for Dr. Rubin. Going back through years of watching people post on message boards and some of the questions that have popped up today, misdiagnosis is one of the big questions that always arises. And we have the tools which you described in your talk to get an accurate diagnosis. It's just
Mhm.
not all of the centers have those tools available or the expertise to analyze the information. And you'd mentioned in your talk that people can have these samples sent elsewhere to get tested or reviewed. Do patients need to be proactive to ask for that? Are they going to be told that those are options? What does it look like if someone's in a rural hospital setting to get a sample to your lab in Cleveland Clinic, for example, to get reviewed?
You need to be proactive. Once a pathologist made a diagnosis, it's out of his mind or her mind. They'll never revisit it unless there's a reason to do it. So they're not going to automatically send it. Now, if they're struggling, and I get about 4,000 consultations each year from all over the United States for people who are struggling with a cancer. They're not sure what it is. They know it's something in my area. They know I'm an expert, so they'll send it to me. And once it's been sent to me, you see that on your pathology report. It'll say, this case was seen in consultation by Dr. Brian Rubin of the Cleveland Clinic, who rendered the following diagnosis. However, if you don't see that, and it looks like that, somebody has just diagnosed it, they may not be at a sarcoma center. Um, Even just get a second opinion, even if I've seen it, you might want a second opinion. In pathology world, we like second opinions, and Jonathan Epstein's probably one of the most famous pathologists in the country. He's a prostate guy, and he was at Hopkins for a long time. Jonathan Epstein was famous for going on to shows and saying everybody who gets a cancer diagnosis should get a second opinion because, again, medicine is gray. It's not so black and white, and it doesn't hurt to get a second opinion. It's not expensive. Now, so be proactive. If you don't see a lot of evidence that the thing's been reviewed somewhere else, you're worried that you don't have the right diagnosis, you just want a second opinion. Very simple. You contact the hospital where your pathology is. You tell them you want a second opinion. You tell them where you want it to be sent. They will send it. If they don't have the proper information, they'll like call my office. If they can't call my office, you can email me, you can call me. I will give you the right information. But again, you don't need to send it to us at the Cleveland Clinic. We're happy to look at it. But that said, lots of great multidisciplinary sarcoma centers. Dr. Venkat is at Moffitt, very good place. Um, you know, there's other places to send it. Again, we're happy to look at it, but there is a universe of very solid pathologists out there who can look at it. But you got to be proactive, very easy to do. And it's not that expensive. Insurance typically covers a second opinion. If it's not covered, it's not tens or hundreds of thousands of dollars. Most it's a couple $1,000.
Thank you for that. Dr. Venkat, I have a question that came in here that's sort of in reference to one of the points that you made about if a tumor is not bothering you, if it's not actively growing, if it's not painful, don't touch it. There's on the flip side of that, there's a lot of fear and confusion from folks who have something growing in their body that's not supposed to be there. When, what is the right time, and how does a person navigate figuring out what the right time is? And is there kind of a point of no return where something says, okay, I think Dr. Bowie alluded to this too. If something's been there for a long time, but it's gotten quite big over a very slow period of time, what is the time where you say, okay, it's time to act?
No, I mean, and it's so counterintuitive to what I tell different groups. So like imagine you are battling a hepatocellular cancer. I want it as soon as we see it because I want it small so I can make big zones. I know I can make an impact.
Mm-hmm.
Here with EHE, just because so many of them are there and have been there, and I don't know how they're acting, I find I don't like jumping into the intervention the first time we meet. I
Mm-hmm.
prefer, even if it's 4 weeks, just give me one more time point to how this acts and who is it acting.
Mm-hmm.
Because they're so different, and you really want to choose something that's going to be effective without giving up this beautiful background of normal parenchyma that will be fine for years if you don't tip it in a bad way.
Mm-hmm.
Um, and then so it's the other reason you don't do it alone. And we do a lot of like calling, whoever your local oncologist and say like, hey, what do you think? Is it time? Is it not time? And you got to respect it. And I really, really, really put a lot of pressure on surgeons because surgeons are very good at getting a feel for like how's the liver act and what time. And they're much more patient than we are in terms of interventions, in the
Mm-hmm.
sense that they really, really strongly will teach you about what's called a test of time. So you want to understand someone's biology, and the only way to do that is to give it a little time and to look again.
Mm-hmm.
Does that make
Absolutely.
sense?
Yeah, absolutely. It also gives some context and appreciation for why it's so important to go to a center that has experts across disciplines that can have those important conversations about what the right decision is for you, and for a person as a patient to be willing to have that conversation with a group of providers and say, okay, have you all talked? Do you all agree? And that it's okay to have that conversation as well.
All right, we're at time for the session. Thank you very, very much.